Imagine a medical success story so, you know, profoundly effective that it basically accidentally created an entirely new crisis of the human condition.
Right.
Because for the vast majority of human history, living past the age of 60 was essentially a biological coin toss. But over the last century, public health, sanitation, and modern medicine have effectively doubled the human lifespan.
Yeah, which is incredible, but...
Right, we engineered a way to keep the machine running.
Yeah.
But here's the catch. We didn't necessarily update the software on how to actually live in those extra decades.
No, we didn't.
We built a society that expects you to be young and, like, hyperproductive, and when you inevitably slow down, the cultural narrative just sort of points you toward a waiting room and expects you to quietly fade away.
It is, it's one of the most persistent, deeply ingrained cultural blind spots we have.
Totally.
We're conditioned to view aging as a purely binary state. You know, you are either young, autonomous, and capable, or you are old, dependent, and fundamentally defined by what you have lost.
Just categorized by the loss.
Exactly. We categorize the entire latter third of the human lifespan as this slow, irreversible decline.
Which is incredibly bleak. I mean, if you're approaching that stage of life, or if you're caring for someone who is, that narrative can feel suffocating.
It really can.
But when you look closely at modern gerontology, at the actual frontier of geriatric counseling and palliative care, that narrative is completely dismantled.
Oh, absolutely.
We aren't looking at a waiting room anymore. We're looking at this incredibly active, dynamic effort to optimize human dignity right up to the final breath.
It is a total paradigm shift in how we approach healthcare. Historically, medicine has been obsessed with the idea of a cure.
Right, fix the problem.
Exactly. Find the pathogen, kill it. Find the broken bone, set it. But modern geriatrics and palliative care acknowledge that eventually the body cannot be fixed in the traditional sense.
Yeah.
So the goal shifts from merely surviving, from just, keeping a pulse going, to actively maximizing function, meaning, and psychological well-being.
So, welcome to the deep dive. If you're listening to this, you're a fellow curious learner. And today, you and I are going on a really profound journey into the reality of getting older.
It's going to be a fascinating one.
It really is. We are taking a comprehensive look at the biopsychosocial reality of aging, how modern clinicians actually assess and promote health in older adults, the incredibly nuanced art of gerontological nursing, and finally, the profound psychological therapies used in palliative care.
Right.
Our mission today is to understand exactly how medicine and psychology are basically rewriting the end of the human story.
And to really grasp that, we have to start at the foundation.
Okay, lay it on us.
Before we can talk about nursing or meaning-making or palliative care, we have to understand the biological machine we are working with.
The nuts and bolts.
Exactly.
Yeah.
We need to look at what is actually happening at a cellular and systemic level as we age, which brings us to a crucial biological concept, senescence.
Senescence. Let's unpack that, because I feel like people often use getting old and getting sick interchangeably, but they are absolutely not the same thing.
Precisely. They are not. Senescence is the normal, inevitable biological process of alteration in the body and its organ systems over time.
Okay.
It is the gradual accumulation of irreversible functional losses. And the key word there is normal.
Normal. So it's not a pathology.
No, senescence is not a disease. It does not mean you are actively dying. It simply means that your biological systems are losing their maximum efficiency and, crucially, their reserve capacity.
I think about it a bit like structural fatigue in a massive suspension bridge.
Oh, that's a good analogy.
Like the bridge isn't broken. It's still carrying traffic every single day. But over decades of, expanding in the summer heat, contracting in the winter freeze, and bearing the weight of millions of cars, the microscopic integrity of the steel cables changes.
Right, it wears down.
Exactly. The margin for error shrinks. If a massive hurricane hits, a brand new bridge might sway and recover. But the older bridge is vastly more vulnerable to catastrophic failure.
That is a phenomenal way to visualize it, because it perfectly describes the concept of organ reserve.
Okay.
When you are 20, your organs operate with massive excess capacity. You can run a marathon, get dehydrated, catch a virus, and your body compensates instantly.
Right, you just bounce back.
But with senescence, that reserve is depleted.
So let's ground this in the biology. Walk me through what that actually looks like in the body, maybe starting with the respiratory system. Because the lungs are basically our main interface with the outside world. and they really take a beating.
They absolutely do. I mean, over a lifetime, your respiratory system filters millions of cubic feet of air, along with all the environmental pollutants, dust, and microscopic debris that comes with it.
All the junk?
Right. And inside your airways, you have cilia, these microscopic hair-like structures that constantly sweep mucus and foreign matter up and out of the lungs.
Like a little biological escalator.
Exactly like an escalator. But as senescence sets in, those cilia diminish in number, and the ones that remain become, well, sluggish.
So the escalator that clears out the garbage just stops working effectively.
Exactly. And simultaneously, the actual muscle strength in the chest wall decreases, and the the tiny air sacs where oxygen exchange actually happens,
Yeah.
they lose their elasticity.
Wow. So everything is just less efficient.
Yeah, so you have a situation where less oxygen is getting into the blood and foreign particles and bacteria are lingering longer in the lungs.
Oh, I see where this is going.
Right. This is why a simple upper respiratory infection in a younger person is, an annoyance, but in an older adult, because that bridge has lost its structural reserve, it can rapidly progress to chronic bronchitis, emphysema, or life-threatening pneumonia.
The margin for error is just gone.
Completely gone.
What about the cardiovascular system? Because we always hear about, hardening of the arteries, but what is the actual mechanism driving that?
Well, it's a combination of structural degradation and cumulative damage. On a cellular level, the heart muscle itself changes. Functioning muscle cells are gradually replaced by fat and fibrous tissue.
So the heart literally becomes stiffer.
It literally becomes stiffer. There is a loss of elastic tissue in the blood vessels and an increase in collagen. And when your arteries lose that elasticity, they can't expand and contract to accommodate blood flow as easily.
Which means the heart has to work overtime.
Exactly. It forces the heart to pump harder just to maintain baseline circulation.
And this is where atherosclerosis comes in, right? Because a stiffer tube is also more susceptible to getting clogged.
Yes. Atherosclerosis is the buildup of fats, cholesterol, and other substances in and on the artery walls. Over decades, especially exacerbated by, diets high in saturated fats or factors like smoking, these plaques calcify and narrow the arteries.
Right.
So blood has a significantly harder time reaching the peripheral organs. And you also see changes in the veins, particularly in the legs, where valves weaken and blood cools under high pressure, causing swelling.
Okay, so the lungs are losing their sweeping power, the heart is getting stiff.
Okay.
Let's talk about a system that carries a massive amount of social stigma, but is absolutely critical to understand the renal and urinary system, the kidneys and the bladder.
It is heavily stigmatized, yes. But we have to discuss it because it is frequently the tipping point for independence.
Really?
Yeah. As we age, the kidneys actually lose mass. The number of filtering units, called nephrons, drops significantly.
Okay.
This means the kidneys lose their ability to concentrate and dilute urine effectively.
Which messes with your entire internal chemistry, doesn't it?
It does. It makes the older adult highly susceptible to dehydration, and they lose the ability to regulate salt balance in the blood.
Wow.
But crucially, this slower filtration rate drastically alters how the body processes medications, which we will definitely come back to. But you're right, the most socially devastating impact occurs in the bladder.
The functional capacity of the bladder drops dramatically, right? Sometimes by as much as 50%.
Yes, it shrinks significantly.
But the truly insidious part isn't just the size. It's the signaling, isn't it?
That's the core issue. In a younger person, the bladder sends a signal to the brain that it needs to be emptied long before it is actually full.
Right. You get a warning. You have plenty of time to finish what you're doing, find a restroom, whatever.
Exactly. But with senescence, that neurological signaling is delayed. By the time the brain registers the sensation of needing to void, the bladder is already at absolute maximum capacity.
There is zero buffer time.
Zero. And the sphincter muscles controlling release have also weakened. The result is urinary incontinence.
Right.
It is incredibly common, affecting roughly half of all older persons living in their own homes, and a vast majority of those in long-term care facilities.
And here's where the biology crashes headfirst into the psychological and social reality.
Oh, absolutely.
Because incontinence isn't just a physical inconvenience. I mean, it is deeply tied to human dignity. If you think about it, toilet training is one of the very first forms of bodily autonomy we master as toddlers.
That's a really good point.
Losing that autonomy is a profound psychological blow. And functionally, it is often the exact catalyst that forces a person out of their home.
It is.
Like if an elderly parent starts having accidents in the bed or on the living room rug, the family caregivers usually reach a breaking point. The laundry, the hygiene, the physical labor of cleaning, it just becomes unmanageable.
It precipitates a massive social cascade, a purely biological shift. The loss of elasticity and delayed nerve signaling in the bladder leads directly to a loss of independent residency.
Which leads to the nursing home.
Exactly. The forced transition into a skilled nursing facility and a profound isolating sense of shame for the patient.
Which brings us to the defining question of geriatrics. If senescence, this loss of elasticity, this cellular slowing down, is totally normal, at what point does it cross the line into actual disease?
Right.
Because clearly not every 80-year-old is the same. Some are out running marathons and some are bedbound.
The clinical dividing line is often conceptualized through the lens of frailty. Yes, frailty is not a synonym for old age. It is a distinct, measurable syndrome characterized by severe physiological decline and vulnerability.
It's when the structural fatigue of our bridge becomes an active, daily emergency.
Exactly. Clinically, frailty is identified by a specific cluster of symptoms. Things like unintended, significant weight loss, profound chronic exhaustion, weak grip strength, and abnormally slow walking speed, and very low physical activity levels.
Okay, so a specific set of markers.
Right. When an older adult crosses into frailty, their risk for disability, dependency, and early mortality skyrockets compared to someone of the exact same age who is not frail.
And frailty completely changes how the body handles illness.
Mm-hmm.
Right. This is where we see the transition from acute to chronic conditions.
Yes.
When we are young, we get acute illnesses, a cold, the flu, a stomach bug. They hit hard, they last a week, and they vanish.
But in older age, the incidence of those acute illnesses actually drops. You might get fewer common colds than a kindergartner.
Wait, really?
Yeah, because your immune system has seen a lot of these viruses over the decades. However, because of that lost organ reserve and the presence of frailty, when an acute illness does strike, it is disproportionately dangerous.
The bridge collapses.
Precisely. A mild chest cold in a robust 20-year-old is a nuisance. But that exact same virus in a frail 85-year-old with diminished lung cilia and a stiffened heart can trigger a cascade of hypoxia, hospitalization, and death.
But the real day-to-day reality of geriatric medicine isn't just fending off acute infections, is it? It's managing the chronic one.
It's almost entirely chronic management.
And rarely is it just one. Let's look at a clinical scenario to really understand this. Take a classic case study from the sources. Let's call her Maisie.
Okay, Maisie.
She is 84 years old, and she has congestive heart failure. So her heart isn't pumping effectively, she gets short of breath, and fluid pools in her legs.
Mm-hmm.
But Maisie also has an arrhythmia, an irregular heartbeat, which puts her at a high risk for a stroke.
Right, very common combination.
And on top of that, she has severe osteoarthritis in her knees, making it agonizing to walk.
Maisie represents the absolute norm in geriatrics. She's dealing with comorbidity, the simultaneous presence of multiple chronic conditions. And comorbidity creates a pharmacological and clinical logic puzzle that is incredibly difficult to solve.
Right, because the treatments constantly conflict with each other.
Exactly.
If Maisie's knees are in agonizing pain from the arthritis, a standard doctor might prescribe a strong NSAID, a non-steroidal anti-inflammatory drug like high-dose ibuprofen.
Right.
But NSAIDs cause the body to retain sodium and fluid.
And retaining fluid is the absolute worst thing you can do for congestive heart failure. It will flood her lungs and put her in the emergency room.
Oh, wow. So what do you do?
Well, that's the puzzle. Do you treat the pain and risk heart failure, or protect the heart and leave her immobilized by pain? Furthermore, if her pain keeps her sedentary, her heart muscle weakens further from lack of use.
It's a trap.
It is. Every single intervention in a comorbid patient has a ripple effect across multiple compromised biological systems.
It is a dizzying balancing act.
Yeah.
And that is just the physical body. But we promised to look at the biopsychosocial reality.
Yes, we did.
While the body is navigating this minefield of comorbidity and senescence, what is happening to the mind?
The psychological burden is just as complex as the physical one. The primary psychological task of old age is the continuous redefinition of the self-concept.
The self-concept being like the story we tell ourselves about who we are.
Yes, your cognitive image of yourself. For most of our lives, our self-concept is built on the foundation of our social roles, our utility, and our accomplishments.
Right.
You define yourself as a provider, a mother, a brilliant engineer, the person who fixes things, the person people come to for advice.
But senescence systematically strips those roles away. You retire, so you are no longer the provider. Your children move away. Your physical stamina fades, so you can no longer be the person who builds the deck or hosts the massive Thanksgiving dinner. Your identity is suddenly just sort of hollowed out.
which leaves the older adult with two primary psychological coping mechanisms, assimilation or accommodation.
Assimilation and accommodation.
Yes, assimilation is the healthier, more active route. It means taking your core identity and finding new roles to express it.
Okay, give me an example.
So if you were always a teacher, perhaps you assimilate into the role of a dedicated community volunteer, or you lean heavily into being a mentor to your grandchildren. You find a new container for your identity.
But what happens when the physical body declines so much, like with frailty or severe comorbidity, that you literally can't get out of the house to volunteer? You can't assimilate because the physical vehicle won't let you.
That is when accommodation is required. Accommodation is an internal cognitive adjustment. It requires accepting a new reality and letting go of the need to impress others with past accomplishments.
That sounds really hard.
It is. It is a shift toward a more reflective, perhaps quieter version of the self. But accommodation is incredibly painful because it involves actively grieving the loss of who you used to be.
This is where we see the trauma of role loss.
Yes.
Let's look at two specific scenarios that illustrate how devastating this can be. Imagine a woman whose entire adult life, her fundamental sense of worth, has been anchored in being a caregiver.
Okay.
She took care of her children, then she took care of her aging husband until he passed. Now, in her 80s, her arthritis and heart failure means she suddenly needs someone to bathe her and prepare her meals.
She hasn't just lost her independence, she has lost her ideal self. Her self-esteem collapses because she perceives being a recipient of care as a personal failure rather than a biological inevitability.
Right. Now, contrast that with a completely different type of identity.
Yeah.
Imagine an older woman who had a fiercely brilliant, highly distinguished academic career.
Okay, the academic.
She was always the sharpest intellect in the room, universally respected. Now, long after retirement, she attends a faculty mixer or a social event with younger colleagues. And because she moves a little slower, or perhaps her hearing isn't perfect, she finds herself being talked over or entirely ignored.
Oh, the psychological shock there is profound. She is grappling with the evaporation of intellectual reverence.
Society has just decided her utility has expired.
Exactly, and she is forced to accommodate a self-concept where she is no longer the authority.
This maps so perfectly onto the psychological frameworks we use to understand human development. Like Erikson's psychosocial model is practically built for this exact crisis, isn't it?
It is the cornerstone of understanding geriatric psychology.
Yeah.
Erikson proposed that human personality doesn't stop developing in our 20s. It evolves throughout our entire life across 8 distinct stages.
Right.
The 8th and final stage, which occurs in late adulthood, revolves around the conflict of ego integrity versus despair.
Ego integrity versus despair. It sounds like the title of a Russian novel.
It does, doesn't it?
What does that actually look like in the mind of an 85-year-old?
It is the ultimate existential reckoning. Ego integrity is the ability to look back on your life, the triumphs, the failures, the missed opportunities, the loves, and find a sense of cohesive meaning.
Okay.
It is accepting your life exactly as it happened, recognizing your place in the broader human story, and basically making peace with the inevitability of death.
It's the ability to say, I did the best I could with the time I had, and it was enough.
Exactly. Despair, on the other hand, is the failure to reach that acceptance. A person consumed by despair looks back and feels only bitterness, regret for the path not taken, and a crushing sense of unfairness.
That is heartbreaking.
And the true terror of this stage is the realization that the clock has run out. There is no time left to start a new career, fix a broken relationship, or rewrite the story.
So it just manifests as anger.
Despair often manifests clinically as deep apathy, hostility toward caregivers, or a paralyzing fear of dying.
So let's pull all of this together. If you are a doctor or a nurse, and a patient walks into your clinic, you aren't just looking at a stiffened heart or loss of nephrons in the kidneys.
No, not at all.
You are looking at a fragile biological system navigating complex comorbidity while simultaneously battling the trauma of role loss and staring down the existential abyss of Erikson's despair.
Exactly.
Which means the standard medical model, the 15-minute appointment where you listen to their lungs, write a prescription for blood pressure, and send them out the door, is not just inadequate, it is borderline negligent.
It really is.
You cannot treat that level of complexity with a generic, find and fix algorithm.
You cannot. And that realization is what gave birth to the foundational tool of modern geriatric medicine, which is the comprehensive geriatric assessment.
Let's dive deep into this assessment because it represents a fundamental philosophical shift in how we practice medicine. A typical medical visit is highly transactional. I have a sore throat, you swab it, you give me antibiotics.
Right, but the geriatric assessment is multidimensional and intrinsically multidisciplinary. It doesn't just ask what disease does this person have. It asks how is this person actually functioning in their daily life, and what are the threats to that function. It systematically evaluates physical health, functional capacity, cognition, mental health, and the socio-environmental circumstances of the patient.
And the true cornerstone of that evaluation is measuring functional capacity.
Yes.
In geriatrics, they divide human agency into two incredibly specific categories, ADLs and IADLs. Let's start with the ADLs, the activities of daily living. What are they and how do we measure them?
So ADLs represent the absolute biological floor of independence. These are the basic self-care tasks required for daily survival.
The bare minimum.
Right. They're most commonly measured by the CATS Index of Independence. The CATS scale looks at 6 distinct functions: bathing, dressing, toileting, transferring, fecal and urinary continence, and feeding.
It's a stark, almost brutal metric, and it's binary, isn't it?
Very binary. You either receive 1 point for complete independence in a category or 0 points for requiring dependence.
So there's no partial credit?
Nope. For instance, if you can wash your face and arms but need someone to help you wash your back and legs, you score a 0 for bathing. If you can chew and swallow but you need someone to physically guide the spoon from the bowl to your mouth, you score a 0 for feeding.
I want to focus on transferring for a second because I think people underestimate the sheer physical mechanics required just to exist in a house.
Oh, completely.
Transferring means the ability to get into and out of a bed or a chair unassisted. If you lose that, if sarcopenia and arthritis mean your legs simply cannot push your center of gravity upward, your world instantly shrinks to the dimensions of whatever piece of furniture you are currently sitting on.
It is arguably the most critical ADL for remaining at home. If you cannot transfer, you cannot reach the toilet, you cannot reach the kitchen, you are entirely dependent on another human being's physical strength to move you.
So the CATS scale measures your ability to survive inside your own body. But to survive in society, you need a higher level of function. Which brings us to the IADLs, the instrumental activities of daily living.
Yes, and these are measured by the Lawton scale. IADLs require complex cognitive and organizational skills on top of physical mobility.
Okay, like what?
The Lawton scale asks, can you operate a telephone? Can you manage your own finances and write a check? Can you navigate transportation or drive? Can you go grocery shopping? Can you prepare a hot meal from scratch? Can you manage your own laundry and housekeeping?
And crucially, can you manage your own medications?
Exactly. Can you take the correct dose of the correct pill at the correct time of day?
Right.
Failing on the Lawton scale, losing your IADLs, is usually the first warning sign of cognitive decline or early dementia. You might still be able to dress and feed yourself, passing the CAT scale, but if you are suddenly paying your electric bill 3 times in a month and getting lost on the way to the grocery store, your independence is severely compromised.
Losing those IADLs carries a massive psychological weight. When a doctor or a family member says, "We need to take away the car keys," or "I need to take over your checkbook," they aren't just managing logistics.
No, they're not.
They are stripping away the hidden agency of adulthood. They are reverting the older adult back to the status of a child who requires supervision.
Which loops right back into the trauma of role loss and Erickson's despair.
Okay, I have a massive practical question here.
Go for it.
I look at this geriatric assessment. We have to evaluate the heart, the lungs, the frailty, the cognitive status, the ADLs, the IADLs, the depression risk, the environment. How on earth is a clinician actually doing this?
A lot.
Because the reality of modern healthcare is a waiting room packed with people, insurance dictates tight schedules, and doctors are completely burned out. How does this comprehensive ideal survive contact with reality?
It's a vital question. If you try to do a full textbook geriatric assessment in a single visit, you will completely exhaust the elderly patient and you will destroy the clinic schedule for the rest of the day.
Right.
To solve this, geriatricians utilize a strategy called the rolling assessment.
So they essentially triage the assessment over time.
Exactly. You break the multidimensional assessment into manageable targeted domains and spread them over a series of sequential visits.
Oh, I see.
In the initial visit, you might focus purely on the immediate acute complaint, basic vital signs, and a quick CATS ADL screen. 2 weeks later, the patient returns, and that visit is dedicated solely to a deep dive into their medication list and a cognitive screening. A month later, they focus on mental health and social support.
And they lean heavily on pre-visit questionnaires, right?
Mm.
I imagine handing a patient a clipboard in the waiting room does a lot of the heavy lifting.
It does, but it serves a dual purpose that is quite brilliant. Yes, having the patient fill out a form detailing their IADLs saves the doctor time. But the act of filling out the form is, in itself, a diagnostic test.
Oh, wow. That's fascinating.
If a patient is handed a 4-page questionnaire and they complete it accurately, they have just demonstrated adequate fine motor skills to hold a pen, sufficient visual acuity to read the text, the cognitive stamina to comprehend the questions, and the executive function to organize their thoughts.
Right.
But if the clipboard comes back blank, covered in confused scribbles, or only half finished, the clinician instantly knows there is a severe deficit in cognition or physical function before they even say hello.
It's a real-time stress test of their IADLs.
Exactly.
And one of the most vital things they're triaging during these rolling assessments is the medication list, which brings us to the absolute nightmare that is polypharmacy.
Polypharmacy is one of the greatest man-made threats to the older adult. It is generally defined as the concurrent use of multiple medications.
And we aren't talking about 2 or 3 pills, are we?
Not at all. Many older adults with chronic comorbidities are taking 8, 9, or even 12 different prescribed and over-the-counter medications every single day.
And remember the biological senescence we discussed in the first section. The liver is the body's primary chemical processing plant, and the kidneys are the waste disposal system. Both of them have lost massive amounts of functional reserve.
Exactly. Because of decreased hepatic blood flow and changes in liver enzymes, drugs are not broken down as quickly. Because the kidneys have lost nephrons, the drug metabolites are not excreted as efficiently.
So you have 8 different volatile chemicals entering a system that filters incredibly slowly. The drugs just back up in the bloodstream. The toxicity cascades must be staggering.
They are, and what makes polypharmacy so dangerous is that adverse drug reactions in older adults rarely look like a classic allergic reaction.
You don't.
No, they don't usually break out in hives. Instead, drug toxicity frequently mimics the classic signs of aging or dementia.
Give me a specific example of how this cascade works in practice.
Let's say our patient, Maisie, is given a new diuretic to help clear fluid from her heart failure. But because her kidneys filter slowly, the drug builds up, causing her blood pressure to drop too low. She feels dizzy. She goes to a different doctor who doesn't check her full medication list and diagnoses her with vertigo, giving her an anti-dizziness medication. That medication has a side effect of severe lethargy and confusion.
So now she appears sluggish and her memory is foggy.
Right. Her family assumes she is developing Alzheimer's disease. Her primary doctor sees her confusion and prescribes an antipsychotic or a strong antidepressant to manage her behavioral changes.
Oh my God.
The antipsychotic causes severe muscle rigidity and throws off her balance. She stands up in the middle of the night, loses her balance, falls, and shatters her hip.
All because the initial diuretic dosage was too high for an aging kidney. It is a terrifying domino effect.
Which is precisely why geriatric medicine relies on a critical tool called the Beers criteria.
The Beers criteria.
Yes. The Beers criteria is a gold standard, continuously updated list compiled by a panel of experts. It explicitly categorizes specific medications and classes of drugs that are considered potentially inappropriate for older adults, either because they pose a high risk of adverse events or because there are safer alternatives available.
It's essentially a do-not-fly list for geriatric pharmacology.
Yes. A thorough rolling assessment always involves reconciling the patient's pill boxes against the Beers criteria and actively deprescribing anything that is doing more harm than good.
But the goal of the geriatric assessment isn't just to catch polypharmacy or document someone's decline on the CAT scale, right? It's fundamentally proactive. It's about health promotion and prevention. We have to push back against this idea that physical collapse is inevitable.
It is absolutely not inevitable. The human body, even in advanced senescence, remains remarkably responsive to intervention.
Really?
Yes, and the single most powerful intervention is physical exercise. Even if an individual begins an exercise regimen in their 70s or 80s, the physiological and psychological benefits are immense.
That's incredibly encouraging.
It improves cardiovascular endurance, helps manage the pain of arthritis, enhances cognitive function by increasing blood flow to the brain, and most importantly, it prevents falls.
Let's talk about falls, because they're a massive looming threat in geriatric care. When you are 20, you trip on a curb, scrape your knee, and go about your day. When you are 80, a fall is a life-altering event.
The statistics are harrowing. A significant percentage of older adults who suffer a major hip fracture never regain their prior level of independence, and a shocking number, up to 20%, die within a year of the fracture.
But they don't die from the broken bone itself, do they?
No, they don't. They die from the complications of immobility.
Right.
The fracture puts them in a hospital bed. Because they are immobilized, their lungs don't expand fully, allowing fluid and bacteria to pool. They contract hospital-acquired pneumonia. Or the trauma and the pain medications trigger acute delirium. The fall is the catalyst, but the comorbidity and reduced organ reserve dictate the fatal outcome.
So preventing the fall is paramount. And what are the primary physical risk factors for falling is a condition called sarcopenia.
Yes, sarcopenia is the age-related involuntary loss of skeletal muscle mass and strength. It particularly affects the fast-twitch type 2 muscle fibers.
Those are the muscles responsible for explosive movement and quick reflexes.
Yes. So if an older adult with sarcopenia starts to trip over a rug, their brain registers the stumble, but the weakened muscles simply cannot react fast enough to catch their center of gravity.
They just can't catch themselves.
Exactly. Sarcopenia destroys balance and gait stability. Targeted, resistance-based physical exercise is the only way to directly combat sarcopenia and rebuild that neuromuscular reflex.
But it's not just about fortifying the body against the environment. It's about fixing the environment itself. Part of the comprehensive assessment involves home hazard mapping.
You have to view the home through the lens of a compromised sensory system. As vision declines, particularly depth perception and contrast sensitivity, a slightly raised threshold between a hallway and a bathroom becomes invisible.
It basically becomes a death trap.
Exactly. So health promotion means aggressively modifying the environment, removing all loose area rugs, vastly increasing the wattage and availability of lighting, especially on paths to the bathroom at night.
Right, simple fixes.
Demarcating the edges of stairs with high visibility, textured tape, installing sturdy grab bars in the shower. These interventions cost very little, but drastically reduce the mortality risk of living independently.
Okay, so we have mapped out this incredibly complex reality. We have failing nephrons, comorbidity cascades, the Katz-Lawton functional scales, polypharmacy risks, and home hazard modification.
It's a massive web.
It is. But here is the reality. Czech physicians diagnose disease and prescribe treatments. They do not have the bandwidth to manage the intricate day-to-day, hour-by-hour reality of an older adult's life. Someone has to synthesize all of this data and actually care for the patient.
And that brings us to the linchpin of the entire system, which is gerontological nursing.
Let's define exactly what this discipline is, because it is far more than just basic bedside care.
The practice of gerontological nursing is an evidence-based, highly specialized nursing discipline. It is dedicated to addressing not just the physiological needs of older adults, but their social, psychological, developmental, economic, cultural, and spiritual needs as well.
Wow.
It is a truly holistic practice.
I think of the gerontological nurse as a high-level systems integrator, or maybe a diplomat in a highly volatile zone.
A diplomat is a great way to put it.
You have the physician shouting orders about blood pressure, the physical therapist demanding mobility, the frantic daughter who is terrified her mother is going to fall, and the patient herself who just wants to be left alone to watch her favorite show in peace.
Exactly.
The nurse has to take all of those conflicting agendas, translate the medical science into practical reality, and negotiate a care plan that actually preserves the patient's dignity.
That is a perfect description of their role. They operate across every single setting in the patient's home, in acute hospital wards, in skilled nursing facilities, and in palliative care.
They're everywhere.
And their core philosophy is a shift away from just managing a disease toward promoting wellness, resiliency, and person-centered care.
But to be that diplomat, to effectively negotiate that care plan, the nurse has to understand who they are negotiating with. You cannot apply a rigid, one-size-fits-all approach to aging because an 85-year-old immigrant from Southeast Asia is going to have a fundamentally different view of medicine, family duty, and suffering than an 85-year-old born in rural Texas.
Which is why the discipline heavily emphasizes culturally congruent practice. A gerontological nurse must ensure that the care they provide aligns seamlessly with the older adult's cultural values, beliefs, and worldview.
There's a fantastic framework used in the field to achieve this, known as the Asked mnemonic, ASKED. Let's walk through it, because it is a brilliant tool for ensuring cultural humility rather than just cultural stereotyping.
It really forces the clinician to interrogate their own assumptions. A stands for awareness. The nurse must first ask, am I aware of my own personal biases and prejudices toward other cultural groups or toward aging itself? S is for skill. Do I have the actual clinical skill to conduct a sensitive cultural assessment and ask the right questions?
K is for knowledge. Do I have a baseline understanding of this patient's specific worldview, their biological variations, and their cultural relationship with illness?
E is for encounter. Am I actively seeking out face-to-face interactions with patients from diverse backgrounds to continually refine my understanding rather than just reading about them in a textbook?
That one is so important.
And finally, D is for desire. Does the nurse actually want to become culturally competent? Is it a genuine internal drive to provide better care, or are they just checking a mandatory diversity box on a hospital form?
Let's apply this to a real clinical scenario. Imagine a gerontological nurse caring for an older patient from a culture that views stoicism in the face of pain as a profound spiritual virtue.
Okay.
The patient has severe cancer pain, but completely refuses morphine because they believe enduring the suffering is a necessary test or a way to protect their family from distress.
Right. A standard biomedically focused practitioner might view that patient as non-compliant or stubbornly refusing treatment. They might try to force the medication, creating immense distress.
Which just makes everything worse.
But a nurse utilizing the ASCADE framework and culturally congruent practice will recognize the cultural mechanism at play. They will sit down, validate the patient's worldview, and negotiate a pain management strategy that perhaps uses alternative therapies or utilizes the family hierarchy to find a compromise that relieves the extreme physical agony without violating the patient's spiritual integrity.
It is about deep, fierce advocacy. And advocacy is actually codified into their profession, isn't it? The Nursing Code of Ethics, specifically Provision 1, explicitly states that the nurse must practice with compassion and respect for the inherent dignity, worth, and unique attributes of every single person.
And we see the most profound expressions of that code of ethics not in massive life or death codes, but in the quiet daily integration of the art and the science of nursing.
Let's talk about the bath scenario, because I think this perfectly illustrates the battle between institutional efficiency and human dignity.
In any care facility, the science of nursing and hospital protocol dictates that a patient must be bathed regularly. It is essential for hygiene, for preventing skin breakdown, and for infection control.
Right.
Institutions thrive on routine, so baths are often strictly scheduled for, say, 8 in the morning.
But imagine you are an 82-year-old woman with dementia. You have been stripped of your home, your IADLs, your independence. You are living in a strange room. At 8 a.m., a clinician you barely know comes in, pulls off your blankets, and insists on stripping you naked to wash you.
It is a horrifying invasion of autonomy.
It causes intense anxiety, combative behavior, and deep trauma.
But the art of gerontological nursing recognizes that trauma. The nurse steps in, evaluates the patient's lifelong habits, and realizes this woman always took warm baths before bed to relax. So the nurse advocates to change the schedule.
Wow.
They practice a calm, gentle approach and move the bath to 8 p.m.
It aligns with her history, it promotes natural sleep, and it drastically reduces her anxiety. Moving a bath by 12 hours seems like a trivial logistical detail, but for that patient, it is the difference between feeling like a piece of meat on an assembly line and feeling like a respected human being. It is the restoration of autonomy.
It is the absolute embodiment of person-centered care.
But we have to face the ultimate reality here. Despite the most meticulous rolling assessments, despite aggressively managing polypharmacy, and despite the most compassionate, culturally congruent nursing care, the structural fatigue of the biological bridge eventually becomes critical.
It does.
Chronic illnesses progress. The heart failure worsens. The organs lose their final reserves. We reach a terminal phase, and when the body can no longer be maintained, the goals of care must undergo a profound pivot. We transition into the realm of palliative care.
This transition is often the most misunderstood phase of healthcare, and we really need to clarify a massive cultural misconception here. People almost universally use the terms palliative care and hospice interchangeably.
They think calling in palliative care means the doctor has given up and death is imminent within days.
Exactly, and that fear prevents millions of people from receiving the help they need. Palliative care and hospice are related, but they are clinically distinct.
Let's break that down.
Palliative care is a specialized medical approach focused entirely on providing relief from the symptoms and stress of a serious illness. The crucial distinction is that palliative care can be provided at any age and at any stage of an illness.
So a patient can be receiving palliative care to manage their severe nausea and pain, while simultaneously receiving aggressive curative chemotherapy to try and beat their cancer.
Precisely. Palliative care operates concurrently with curative intent.
Okay.
Hospice, however, is a highly specific subset of palliative care. Hospice is initiated only when curative treatments are no longer viable or are actively refused by the patient, and a physician determines that the patient's life expectancy is 6 months or less, assuming the disease follows its natural course.
So hospice is the formal acknowledgement that the end of life is actively approaching, and the sole focus is comfort and dignity.
And that formal acknowledgement, hearing a doctor say that the illness is terminal, triggers a psychological tidal wave.
It forces the patient and their family to confront their own mortality in a way that our death-denying culture leaves us completely unprepared for. The psychological landscape of dying is incredibly turbulent.
The foundational framework for understanding this turbulence is Elizabeth Kubler-Ross's stages of coping with dying. Now, it is vital to note that these are not neat, linear steps that a patient checks off on a list. They are overlapping, chaotic emotional states.
It usually begins with shock and denial, right?
Yes. The initial diagnosis is often met with a literal inability to comprehend the reality. It's a defense mechanism. Patients may insist the lab results were mixed up.
Yeah.
They may engage in frantic attempts to gain control by seeking out obscure alternative treatments or traveling the country for endless second and third opinions, convinced that if they just find the right doctor, the reality will change.
And when the denial can no longer be sustained by reality, it shatters and gives way to confrontation or anger, the why me phase.
It is a phase characterized by intense, volatile emotion. Patients feel profound helplessness and panic. They may lash out at their nurses, their spouses, or their God. It frequently involves a devastating loss of faith or a deep disillusionment with religious beliefs that they felt should have protected them.
And if they can navigate through that anger, they ideally reach accommodation or acceptance. This isn't a happy state. It's often a quiet, depleted state. It is the process of integrating the reality of death into their identity, saying their goodbyes, and slowly detaching their emotional energy from the physical world.
Exactly.
But underneath all of those shifting stages, there are specific primal fears driving the patient's psychological agony. The literature outlines a few key terrors. There's the fear of the unknown, what actually happens after the monitor goes flat. There's the fear of losing self-identity, which we explored with role loss. And there's a terrifying fear of regression.
The fear of regression is profound. It is the terror of losing control of one's bodily functions, of becoming dependent on others to be wiped and fed, of reverting to an infantile state in front of your children.
That's heavy.
It is the ultimate loss of dignity. But across all the studies and clinical observations, the single most pervasive, agonizing fear of the dying patient is the fear of being alone.
And fear of separation.
It is an evolutionary panic. We are pack animals. The thought of stepping off into the void while the rest of the tribe stays behind generates a nameless dread. And this dread doesn't just stay in the mind, it infects the entire family unit, creating a feedback loop of anxiety in the hospital room.
And here's where modern medicine made its most revolutionary discovery regarding end-of-life care. That emotional terror, that nameless dread, directly impacts the physical biology of the patient. Which brings us to the monumental concept of total pain.
This concept was pioneered by Dame Cicely Saunders, a brilliant British physician, nurse, and social worker who founded the modern hospice movement at St. Christopher's Hospice in London in 1967. Before Saunders, the medical establishment viewed pain purely as a neurological mechanism. Tissue is damaged, a nerve sends a signal to the brain registers pain. You fix it by blocking the nerve with drugs.
It was treated as a basic plumbing problem.
But Saunders, through her extensive work with the dying, recognized that human suffering cannot be reduced to biology. She introduced total pain, which dictates that a patient's pain experience is a complex amalgamation of physical, psychological, emotional, and spiritual pain. They are inextricably linked.
Let's explore the actual neurobiology of this
Yeah.
because it is fascinating. If you are lying in a hospital bed and you are terrified of what happens after death, or you are agonizing over a bitter, unresolved estrangement from your son, your central nervous system is in a state of high alert.
Exactly. Emotional trauma and anxiety trigger the sympathetic nervous system, the fight or flight response.
Yeah.
Your muscles physically clench, cortisol floods your system.
Right.
And crucially, this state of high anxiety lowers your neurological threshold for nociception.
Meaning your brain actually becomes hypersensitive to physical pain signals. The spiritual terror physically amplifies the biological pain.
The clinical implications of this are massive. If a patient is writhing in bed, consumed by existential despair or unresolved guilt, no amount of physical medication, no dosage of morphine or fentanyl will ever fully alleviate their suffering.
Because you aren't treating the root cause.
Right. The drugs might temporarily knock them unconscious, but the moment they wake, the agony returns, because the root of the pain is spiritual, not biological.
Which poses an incredible challenge for the healthcare system. Because if I am an oncologist or a floor nurse, I am trained in pharmacology, anatomy, and cellular biology. I am not a priest, a philosopher, or a therapist. How is a standard clinician supposed to treat a severed relationship or a fear of the cosmic void?
The simple answer is they can't do it alone. This is exactly why palliative care mandates a multidisciplinary team. It relies fundamentally on the integration of clinical social workers, chaplains, and advanced psychological counselors.
It takes a village.
It does. The physician manages the physical pain receptors, but the counselor and the chaplain must simultaneously treat the spiritual and emotional receptors. Because if they don't, that untreated psychological suffering leads directly to the most severe crisis in end-of-life care.
The absolute collapse of the will to live.
Yeah.
Which brings us to the incredibly complex, often taboo subject of mental health, depression, and suicide risk in the palliative setting.
When total pain is left unresolved, the psychological despair can become absolute. And the first major clinical hurdle is simply recognizing that despair, because clinical depression in older, dying adults is massively misdiagnosed.
There is a pervasive, almost unconscious ageism in healthcare that assumes feeling depressed is just a natural, logical consequence of getting older and getting sick.
Yeah.
Like, of course she's depressed, she's dying.
That assumption is incredibly dangerous. Sadness and grief are normal. Major clinical depression is a pathology that requires treatment. But differentiating between the two in a palliative setting is incredibly difficult because the physical symptoms of dying, extreme weight loss, profound fatigue, lethargy, loss of appetite are identical to the somatic symptoms of major depression.
So how does a clinician tell the difference?
They have to look past the physical body and assess the psychological state, specifically looking for anhedonia, the absolute inability to experience pleasure, and a total loss of self-worth.
Okay, anhedonia.
Right.
Yeah.
A patient who is naturally grieving their terminal illness might still find joy in holding their grandchild or listening to their favorite music. A clinically depressed patient is entirely hollowed out.
And untreated clinical depression is the primary driver of what the medical literature refers to as the desire for a hastened death. And this is where the clinician is forced to walk the sharpest ethical tightrope in all of medicine. How do you evaluate and manage suicide risk in a patient who is already terminal?
It requires an intense, deeply nuanced psychological evaluation. When a patient says, "I just want to die," the clinician must parse out the exact root of that request.
Right.
Is it a desperate cry for better physical pain management? If we adjust their medications and eliminate the agony, does the desire to die disappear?
Often it does.
Yes, very frequently. Or is it driven by clinical depression that can be treated with psychiatric intervention? Or, and this is the most difficult scenario, is it an existential, rationalized desire to regain control over a body and a situation that has completely stripped them of all autonomy?
And when a patient is in unimaginable refractory pain that simply cannot be controlled by standard measures, we enter the complex ethical and legal territory of comfort care and terminal sedation.
This is a debate that has raged in medicine for centuries. It dates back to the 1870s when Dr. Samuel Williams publicly argued for the use of morphine to completely alleviate a dying patient's agony, even with the explicit knowledge that high doses of morphine suppress the respiratory drive and will inevitably accelerate the patient's death.
So you increase the morphine drip to obliterate the pain, knowing full well it will stop their breathing sooner rather than later.
Yes. In the United States, and in many legal frameworks, this is justified under the principle of double effect, a concept originating from Thomas Aquinas.
Okay, the principle of double effect.
It states that an action with two effects, one good, relieving pain, and one bad, causing death, is ethically permissible if the intent is purely to achieve the good effect.
So legally, if the physician's explicit intent is only to provide comfort care, the acceleration of death is accepted as a tragic but unavoidable secondary consequence.
However, the exact same physical action increasing the morphine drip to stop the suffering is categorized differently elsewhere. In some European contexts, this is explicitly termed passive euthanasia because the physician and the patient openly acknowledge that the medication is being used to hasten death in order to end the suffering.
It's just different lens.
Exactly. The pharmacology is identical, the semantic, ethical, and legal framing is entirely different.
It is a profound moral burden for the clinicians and families involved. But what happens when the pain isn't primarily physical? What if the morphine is controlling the body, but the patient is still drowning in the existential despair of Erickson's final stage? They feel their life has amounted to nothing, and they are terrified of being forgotten.
To combat that specific spiritual despair, modern psychology has developed advanced therapeutic interventions designed exclusively for the dying. These are not standard talk therapies. They are highly structured models of meaning-making.
Let's dive deep into two of the most remarkable models out there. The first is dignity therapy, developed by Dr. Harvey Max Chukinoff. When I first read about how this actually works, I was absolutely floored by its elegance.
It is a beautifully constructed intervention. Dignity therapy flips the standard medical script. Instead of the clinician focusing on the patient's failing biology, the therapist sits down and invites the patient to talk about their life, their identity, and their deepest priorities.
The therapist uses a very specific set of prompts, asking the patient to reflect on the parts of their life they're most proud of, the times they felt most alive, the specific things they want their family to know, and the advice or hopes they want to leave behind for their loved ones.
The patient is invited to essentially curate their own legacy. And crucially, this conversation is not just a passing chat. It is tape recorded by the therapist.
Right.
The therapist then takes that audio, transcribes it verbatim, and acts as an editor, cleaning up the narrative flow, organizing the thoughts, but preserving the exact tone and voice of the patient.
They bring the manuscript back to the patient, read it with them, and allow the patient to make edits until it perfectly reflects their truth.
And the final product is bound into a physical manuscript called a generativity document. The patient is handed this tangible record of their essence, which they can then bequeath to their family, their children, or whoever they choose.
It is an incredible psychological mechanism. By creating this document, the therapy externalizes the patient's self-worth. It tells the patient, your body is actively failing, your organs are shutting down, but your wisdom, your love, your history, that is permanent. You will not be erased.
It attacks the fear of separation head-on.
It restores an enduring sense of worth. And alongside dignity therapy, the other profoundly impactful model is meaning-centered psychotherapy, developed by Dr. William Breitbart and Dr. Shannon Pepito.
Yes.
And to understand the power of this therapy, you have to look at its historical roots, which are staggering.
Yes, it is heavily based on the work of Viktor Frankl, the Austrian psychiatrist who survived the horrors of the Nazi concentration camps during World War II, which he documented in his seminal book, Man's Search for Meaning.
Frankl observed human beings in the most degrading, horrific, and hopeless circumstances imaginable. Every ounce of their physical agency had been stripped away, yet he observed that some individuals were able to maintain their psychological integrity.
From this, he developed logotherapy, positing that humanity's primary motivational force is not the pursuit of pleasure, but a fundamental will to meaning.
He argued that even when you cannot change your situation, when you are trapped in a camp or trapped in a terminal diagnosis, you still possess the ultimate freedom, the freedom to choose your attitude toward your suffering.
Precisely. Meaning-centered psychotherapy takes Frankl's profound insights and adapts them for patients facing terminal cancer and illness. It is usually structured over 7 sessions where the therapist and the patient actively mine the patient's shrinking world for sources of meaning.
They explore how to find meaning through connection, through storytelling, through experiencing beauty or nature, even if it's just looking out a hospital window. But the most powerful concept they work on is what Frankl called attitudinal values.
Yes. When a patient can no longer do anything, when they can't work, can't walk, can't build anything, the therapy helps them realize that there is profound dignity and meaning to be found in how they bear their suffering.
That is so powerful.
Their courage, their humor, their grace in the face of death becomes a masterpiece they are creating for their family to witness.
It reclaims agency from the illness. The cancer might be destroying their cells, but they maintain total authorship over their spirit. It transforms the end of life from a purely biological failure, a machine winding down into a profoundly human act of creation, closure, and transcendence.
It is the ultimate antidote to Erickson's despair.
We have covered an immense, challenging landscape today. We started by looking at the literal microscopic rusting of the cellular machine, the senescence of the cilia, the loss of nephrons, the stiffening of the heart. We saw how those biological changes cascade into the psychological trauma of role loss and comorbidity.
We examined how modern clinicians use the comprehensive geriatric assessment and functional scales like the CATS and Lawton indices to map that decline, and how gerontological nurses act as the vital diplomats, using cultural humility to preserve dignity in the most vulnerable moments.
And finally, we waded into the deep, turbulent waters of palliative care. We confronted the terrifying reality of total pain, the ethical tightropes of comfort care, and the breathtaking therapies designed to forge meaning in the shadow of mortality.
I think it is vital to remember that this entire conversation is not just an abstract exploration of medical theory. It is the literal blueprint for our own futures.
Yeah, it really is.
This framework is how we will eventually care for our aging parents, how we will support our partners, and inevitably how we will navigate our own decline. Understanding this profound shift from merely trying to survive to aggressively optimizing meaning changes how we should view our entire lifespan.
It reframes the whole journey. And so, as we wrap up this deep dive, I want to leave you with a final thought to ponder on your own. We talked about dignity therapy and that incredibly powerful concept of the generativity document, the physical manuscript of a person's core values, their proudest moments, and their life's meaning.
Consider the life you are living right this very second. If you were to sit down for a dignity therapy session today, what would your generativity document say? Are you actively building the legacy, the relationships, and the meaning you want to leave behind? Because you don't have to wait for the physical limitations of aging to begin drafting your masterpiece. The canvas is wide open right now. Thanks for diving deep with us.